This is the MyHeart.net podcast. This show is produced by Dr. Philip Johnson in conjunction with VitalEngine.com. Please welcome your host, Dr. Alain Bouchard of Cardiology Specialists of Birmingham, Alabama, at St. Vincent's Medical Center, part of Ascension.
Today our podcast is concerning non-valvular AFib and stroke prevention, particularly in patients with contraindication to oral anticoagulation. And with us today, we have a very special guest. He's an electrophysiologist, and he's working with the cardiovascular consultant in Skull State. His name is Yoaav Krauthammer. Yoaav, welcome to our podcast, and thank you for being here today.
Well, it's absolutely a pleasure, and I appreciate the opportunity to be on board.
Thanks. So in patients with AFib, we know that the left atrium is a common source of thromboembolic events, with over 90% of all thrombi identified can be localized in the left atrial appendage. We know that the gold standard for stroke prevention in patients with non-valvular AFib and high risk of stroke is oral anticoagulation with either warfarin or DOACs, medication like Xarelto or Eliquis. However, anticoagulation therapy is associated with significant bleeding risk. So what do you do when you have someone that has a contraindication to anticoagulation? This is probably concerning about 10% of our patient, all the AFib population, with patient with contraindication to oral anticoagulation. And maybe we can add another 20% who have relative contraindication to anticoagulation. So, Yoaav, what do we consider a contraindication to anticoagulation? Who are these patients?
Well, as you pointed out rightly, there's a distinction between the permanent contraindication, the relative contraindication to oral anticoagulation. But the ones that we really deem as an absolute contraindication would be those patients with a prior intracranial hemorrhage, severe gastrointestinal bleeding that has not yet, a source has not yet been found, and those patients that have significant falls risks that have fallen on multiple occasions and have had significant trauma. Those would be the ones that I'd consider absolute contraindications. But, as you rightly pointed out, the 20% that have relative contraindications, it can be very challenging to talk them into even 6 weeks of anticoagulation post-implantation of a Watchman device or other types of atrial appendage occlusion. So I think we lump all of them in really in real life. We lump those 30% in as one single cohort.
Very good. We know that percutaneous left atrial appendage occlusion devices have been developed aiming primarily at stroke prevention in that category, patients that have contraindication to oral anticoagulation. So, Yoaav, see if you could maybe just kind of walk us through the several devices available. And it seems like everything started in the OR.
So you're absolutely right. This all started with a knowledge. We've had the knowledge for many years that the left atrial appendage is really one of the prime sites for left atrial appendage thrombus. And we see that these patients have about a 95% risk of left atrial appendage thrombus in atrial fibrillation, only about a 3 to 5% risk of thrombus in any other cardiac location. And so initially during, the Cox-Maze procedures all the way back in the 70s and all the way through, left atrial appendage exclusion by surgical excision or stapling was the preeminent way to go, though that led to a lot of questions as to what meant a occluded left atrial appendage post-surgically. I'm sure, Dr. Bouchard, you've seen many TEEs on post-surgical patients where there was incomplete closure, the suture had opened or had not been fully closed over the appendage. Over the years, that has developed into an understanding that more intracardiac devices or more robust ways of surgically ligating that appendage are needed, and multiple devices have come out since then to provide that service.
We have so today a lot of our surgeons are using this AtriClip or atrial clip when it's combined with bypass surgery or even valve surgery. Obviously, a lot of these procedures are performed in the OR under TE guidance in the OR. and we have, a lot of kind of data from the surgical data, the STS data, showing that, overall it does reduce the risk of thromboembolic event, maybe in the order of maybe 1.5%, which kind of, it's always, that's very good. It's not obviously perfect, but there's always concern about incomplete occlusion. And in patients that are high risk, we're so reluctant, to discontinue or not use anticoagulation unless they truly have a contraindication. What's your experience clinically in these patients that have an AtriClip?
So I think as the AtriClip device has become more widely used and people with VATS experience are more widely utilizing just video-assisted thoracoscopy to close these appendages, we've seen better and more complete closure results in the surgical world. Unfortunately, it's a small population and the company is a very small company and does not yet have the means to afford a clinical trial to give us really a randomized set of data to make it evident that taking patients off of anticoagulation would be safe after these devices. That being said, we have a lot of real world data that suggests if you perform a post-operative TEE on these patients and they have a stump of less than 1 centimeter after AtriClip closure, that they can safely be removed from anticoagulation. But that is, again, not something that has data to support those real world decisions. That being said, again, I think it's a very valuable technology, not only from an occlusion standpoint, but also from an electrical isolation standpoint of the appendage, which does increase significantly your chance of remaining out of atrial fibrillation.
Well, that's a very good point. And this kind of moves us maybe into the Lariat atrial occlusion device, which is done, at certain centers around the country. Another way to isolate the atrial appendage, in a way sometimes to even get rid of the atrial fibrillation, as well as protecting against, thromboembolic event. What is the experience with the Lariat procedure? Can you describe it maybe a little bit for our patients?
Of course, the Lariat is a less invasive technique to both surgically ligate and to electrically isolate the left atrial appendage. It's basically just a slip knot. It's performed using an epicardial approach under the rib cage. The implanter will then thread a catheter from the rib cage area to the pericardium and into the pericardial space. That is the lining between the sac that holds the heart in and the heart itself. And then using transesophageal echo or TEE guidance, that slip knot is then advanced over the left atrial appendage on the epicardial surface and closed down as you make sure that the appendage is ligated. That is in its last stages right now of enrollment in the AMAZE trial. And that is specifically looking at not only stroke reduction, but is also looking at AFib reduction in patients with non-valvular AFib.
Very good. So these are procedures that are mostly occluding the atrial appendage or isolating it, it seems like from the outside. And a lot of techniques obviously are being developed and tested over the last several years that are using endocardial or endovascular approach. That means going from the inside. And one of those is so-called the implanter or the amulet. A lot of experience here as well as in Europe. Tell us a little bit about some of the results that we have with the amulet device, particularly in patients who cannot take anticoagulation. What's the experience?
As you rightly pointed out, the two devices we previously spoke about are epicardial approaches. They're a bit more invasive. They do carry with it a little bit higher risk of complication. And so endovascular approaches were also under consideration. The first one really that had a clinical trial was the Amplatzer device, which was the old device used by Amplatz Medical to close PFOs and ASDs. And it was used to close off these left atrial appendages as well. Those were in the early and mid 2000s. And then that progressed after Abbott Medical purchased the Amplatzer company into the Amulet device. And that Amulet trial concluded about a year and a half ago. It enrolled thousands of patients throughout the United States that had a elevated CHADS-2 VASC score. That's the scoring system we use to determine how risky you are at developing a stroke due to atrial fibrillation. And that device is basically a ball and disc device. The ball is used to lodge itself into the appendage, and the disc then covers the appendage surface in order to create that seal. The nice thing about this device is that with that ball design, it's a very gentle device to implant. It's very safe to implant into the more challenging anatomy of the left atrial appendage. And that clinical trial was done as dual antiplatelet therapy only after implantation, did not require patients to take oral anticoagulation. And so that device is currently under FDA review. We're waiting for final approval, which I think should be available by the middle to end of 2021.
Interesting. It's called also the pacifier, really kind of interesting from the point of view of its structure. 85% of these patients had contraindication to anticoagulation. So I think very relevant to what we're talking today. And as you mentioned, almost half of them, had dual antiplatelet and no anticoagulation whatsoever. 30% or a third had single antiplatelet, whether it was Plavix or clopidogrel or aspirin. Very interesting. Now let's really, move to Europe and look at the experience, because in Europe, there's an indication for closure device in patients that have contraindication to anticoagulation, and we have to look at the registry. I mean, it's the best that we can get at this point, but it's called Evolution, and the real life use of Watchman device, where over 70% of patients had contraindication to oral anticoagulation. So what's the experience there in Europe, Yoaav, and in those high-risk patients, very high risk?
Absolutely. So for just a little context for our listeners, the original Watchman device was first trialed in 2005 in the PROTECT trial, and then again in the late 2000s in the PREVAIL trial that ended in 2012. And the FDA, and those two trials, along with two registries, provided for FDA approval of the Watchman device, but only in patients that could qualify for oral anticoagulation, namely Coumadin or warfarin, for 6 weeks after implantation. And so in the United States, we have no guideline-directed indication for implanting the Watchman device on no anticoagulation postoperatively. However, in Europe, as you rightly pointed out, they're taking a little bit more of a realistic approach to the way that patients are treated. And there is an indication for dual antiplatelet therapy as a 2B indication in patients who undergo Watchman implantation. That Evolution trial that you referred to, again, you pointed out is a registry trial, but in the lack of other trials or other data that's as good as we have, included about 1,000 patients. It was 1,020 patients. The average CHADS VASC score was significantly higher than the majority of trials in the United States. It was almost 5. And those patients had 72% of them had absolute contraindications to oral anticoagulation, as we discussed previously. Out of those patients, post-implantation, out of those 1,020 patients, only 27% of them were discharged on an anticoagulant. Another 60% were discharged on dual antiplatelet therapy, and the remainder were actually discharged on only single antiplatelet therapy or nothing at all. That data was reviewed at 1 year. And actually what we saw was a similar outcome as all the trials done in the United States that included vitamin K antagonists such as warfarin. When we are implanting on no anticoagulants, the concern is not that we're going to have an ischemic stroke due to atrial fibrillation or incomplete closure. The concern is that we would provide a nidus for thrombus on the face of the device itself because it's a foreign body. And so what we'd actually want to look at is what's called DRT, or device-related thrombus. In all of the trials in the United States that we referenced before, PREVAIL, PROTECT, and the registries, the rate of DRT was about 3.8%. all comers. And that was despite aggressive anticoagulation for 6 weeks after implantation. In the Evolution trial in Europe, that again, as we referenced, over 70% of those patients left on no anticoagulant of any kind. The same rate of DRT was noted. It was at 4%. And so, frankly, this data is suggestive of the fact that DRT is independent of what type of anticoagulant we're using. And so, frankly, I think we have to start looking more aggressively at treating patients with absolute contraindications here in the United States.
Results were very good. I mean, at 2 years, 85% of these patients were just on aspirin. Stroke rate was low, about 1.3%, had, stroke, TIA, or systemic embolization. Around 80%, fewer events than expected. And obviously, we understand it's a registry, so it's not like a perfect trial. Not everybody had, TEs, post-op and follow-up. There's no checking on the data. It's really, a real-life experience. But overall, I think it gives us a feel that, this is really a real contender. And maybe we should be, doing that kind of atrial closure device in patients that have contraindication. Certainly, it looks very promising. So there's a lot of development in these closure devices, Yoaav. There's now the Watchman Flex. Even the Implanter or Amulet is getting, transformation. We're trying to change the design so not only they're easier to place or easier to close the appendage, but also a different design that maybe can decrease the leaks that we have and maybe decrease those DRTs or these device-related thrombi. Can you tell us a little bit about that? Maybe some of the new design that are coming out and how maybe this will propel us, going forward, without maybe too much risk of thromboembolic event after this device without the use of anticoagulation.
Yeah, so the Watchman Flex device, which is the new device, it was FDA approved in July of last year, and is significant, in my opinion, a significant improvement over the original Watchman device, not only from a safety of implantation standpoint, but also I think that we're going to find that it's a much safer device from a DRT standpoint. The reasoning behind that is it includes a significantly increased layer of fabric cap that goes a little bit further down the metal struts of the device, the nitinol struts of the device. That provides a lower profile for the device and also provides less nitinol in contact with the bloodstream. Additionally, it has significantly more tines to hold the device in place, but those tines are not as sharp and don't cause as much tissue breakdown at the site, which I think may be an independent predictor of DRT as well. So from those two standpoints alone, I think you're going to find that this is going to be a safer device from a DRT standpoint. But on top of that, it's also much like the Implanter or Amulet device has a closed back end, whereas the original Watchman device was much more open at the back end. This decreases risk from two perspectives. Number one, that provides less compression needed in the appendage itself, which again, less compression, I think, puts less tension or pressure on the tissue, which may be a predictor of DRT. And number two, provides for a much better seal around the device. And therefore, you'll find less flow and less overall reason for DRT to form.
Well, that's great. So, I think we're about to get onto prospective randomized trial, looking at these new devices. One of them, is ASAP or ASAP2. You were actually part of the ASAP, clinical trial, which used aspirin and Plavix, in a small number of patients, but still very low risk of stroke and really a lot of significant reduction compared just to aspirin alone. Can you tell us a little bit about the ASAP2 and how do you think it's going to impact our clinical practice?
Well, I would love to be able to tell you that we're going to be getting results of that shortly, but unfortunately that's proven to be a very challenging trial to enroll in. As you mentioned, I was a member of that trial and actually was the highest enroller the last 2 years in that trial. But to put that into context, we're looking for a total of 888 patients in that trial. I was the highest enroller in the United States last year, and I enrolled 6 patients. So as you can imagine, getting patients enrolled is a challenge. A lot of that is because practitioners are reluctant to not provide the service for the patient. The ASAP2 trial is set up as a 2-to-1 randomization, where patients with absolute contraindications to oral anticoagulation are randomized 2 patients to a Watchman device. That's the first generation Watchman device, versus 1 patient that'll remain on whatever therapy they came in on prior to the procedure, aspirin, Plavix, or nothing. And the patients who receive a Watchman device will be discharged on only dual antiplatelet therapy for 3 months. We're trying to show that there is clear safety and efficacy of that device in the setting of dual antiplatelet therapy alone. But based on the evolution trial that we discussed previously, a lot of practitioners are choosing to implant off-label rather than risking a patient not getting a Watchman device at all. And so it is challenging to find patients in that trial.
There's another trial also, which is really pretty incredible, the stroke close device that is going on in Europe, I think in the Netherlands, enrolling patients that have had previous intracranial bleed.
Yes, so we're looking at patients with prior intracranial bleed who would be considered at the highest rate of contraindication on patients, and they are being implanted with left atrial appendage occlusion devices and compared to those patients with nothing at all. This is using the amulet device rather than the Watchman device. The amulet device is already approved in Europe, but the control group, the patients that are not getting implanted, will receive whatever therapy they choose at the physician's discretion, and that could be anything from oral anticoagulation to novel oral anticoagulants such as Eliquis or Xarelto, or antiplatelet therapy only. And so we'll have to see how that plays out, but it sounds very similar to the evolution trial, but using amulet rather than just Watchman.
Very good. So it should be really kind of interesting, but it looks to me that the atrial closure device, whether you use amulet or Watchman Flex, is really a viable option for these patients that have contraindication to anticoagulation. Now, Yoaav, you're an electrophysiologist, and there is this very interesting trial, going on, the option, trial in patients that have atrial fibrillation, and where we're studying, whether these patients should have concomitant atrial closure device procedure or it may be done immediately after. I mean, what an interesting concept. I mean, you're going there for an AFib ablation, you may be at risk for, a bleed as well. You're at risk for a stroke. Why not put a atrial closure device at that time or closer? I mean, doesn't that seem logical for our patients?
Well, you're unfortunately attempting to provide logic when it comes to insurance companies, and that's something that is a challenge from the day that insurance was born. But right now, the problem is that insurance companies will only provide fee-for-service for one procedure at a time. And since these are both expensive procedures, it would be too cost prohibitive for hospitals to be able to afford to do both at the same time. This study is groundbreaking in that not only is it going to hopefully show that patients have lower risk of complications when we do both at the same time, and it makes sense just because we're going to provide one less transeptal puncture, one less form of general anesthesia. But number two, it's comparing these Watchman Flex patients and they're using novel oral anticoagulants rather than warfarin, which had not been done previously. And so we'll be able to get some data to justify the use of these novel oral anticoagulants as well.
Very interesting. I guess in here in the United States, it probably could be a staged procedure. I know that, for convenience sake, it wouldn't make sense to be, at the same time. But as you mentioned, not very realistic in the world that we're living in, at least in the United States, maybe in Europe, something like that, can be done. Anything else going on in that field of atrial closure device, Yoaav, and as an electrophysiologist, where do you see us going?
Well, the fascinating news is that last year, Watchman, being the only FDA-approved device, so Watchman's the only one that's listed right now, actually got an indication for closure in the HRS guidelines, which is something that usually takes a lot longer than it did for this device. It's currently listed as a 2B indication, which is the lowest of the scientific recommendations. But I think that over the next 5 to 10 years, you're going to find that Watchman closure or left atrial appendage closure of whatever kind is going to overtake anticoagulants as a first-line therapy. The reasoning is that when you look at the stack data of the 4 Watchman trials, the 2 randomized trials, the 2 registry trials, at 5 years, we see a mortality benefit in patients who have a left atrial appendage occlusion rather than staying on oral anticoagulation. And if you can find something that has a mortality benefit at 5 years, you're going to start seeing this become a first-line therapy, especially in younger patients, which right now are not the ones we're trying to target, but especially in younger patients as you try to provide longer lifespans. Very
interesting. So there's currently probably around 5 to 6 million U.S. patients with AFib, project to be about 15 or 16 million in the last 30 years. You're not going to run out of a job, Yoaav. I mean, it seems like you're going to get busier.
I don't think that electrophysiologists will ever be trying to get through on food stamps. We're going to do just fine.
And help a lot of our patients in the process. Yoaav Krauthammer, and everything you want to know about the atrial closure device in patients that can't take blood thinners. Thank you very much, Yoaav. Appreciate for your time.
Thank you so much. It's my pleasure.
To learn more from our team of cardiologists, please visit us at MyHeart.net. You can also follow us on social media by searching MyHeart.net on Facebook and Twitter. And be sure to subscribe to this podcast so you don't miss our next episode.